This PowerPoint is going to cover obstructive sleep apnea, or OSA. Remember, with obstructive sleep apnea, there is lack of airflow for at least 10 seconds with continued respiratory effort during that 10 seconds. So the patient's muscles are trying to get a breath, but for some reason air is not able to get into the body or back out of the body. Typically, this is due to an obstruction of the upper airway. Some of the clinical symptoms reported by bed partner include snoring, excessive daytime sleepiness, snorting in the sleep, gasping in their sleep, and witnessed apnea. Of course, for the patient, there are many more symptoms of sleep apnea. Let's go on to our next slide. Obstructive sleep apnea syndrome. This is a complete obstructive event of at least 10 seconds. Again, that means airflow is not moving in or out of the body, but the muscles are trying to take a breath. When associated with clinical manifestations, some of their symptoms are going to include unrefreshing sleep, sleep disruption, fatigue, excessive daytime sleepiness, to name a few. UARs, or upper airway resistance syndrome. This is where there's a decrease in airflow between 3 to 25% of prior nasal flow recording. When associated with clinical manifestations, the symptoms are going to include unrefreshing sleep, sleep disruption, fatigue, and excessive daytime sleepiness. Notice the symptoms of upper airway resistance and of obstructive sleep apnea are exactly the same. However, OSA is really the sleep disorder that's treated with CPAP. Oftentimes, upper airway resistance syndrome will not go treated or will be left untreated. Hypopnea is then different from both UARs and OSA. This is a reduction in airflow measured by a nasal pressure transducer of 30% or greater with at least a 4% oxygen desaturation. Or it can be a reduction in airflow measured by a nasal pressure transducer of 50% or greater with at least a 3% oxygen desaturation or associated arousal. Notice that the differences between a hypopnea and the upper airway resistance. The upper airway resistance, the airflow recording isn't as significant as with the hypopnea, and also with upper airway resistance syndrome, notice there isn't a desaturation that occurs with it. Because of these reasons, you don't have hypoxia occurring with upper airway resistance, it's not required, and the airflow decrease isn't as significant as the hypopnea. That is part of the reason that they don't consider it to be as hard on the body, and that it doesn't really need to be as treated as significantly as OSA and hypopnea is. That's some of the reasons. However, if you look at the symptoms, what does a patient complain of? The symptoms of upper airway resistance syndrome are exactly the same as a patient complaining of obstructive sleep apnea or maybe some severe hypopnea as well. Let's go on to our next slide. ARIRA is termed a respiratory-related arousal, and this is where there's a sequence of breaths of at least 10 seconds where there is an increase in respiratory effort or a decrease in nasal pressure waveform which causes an arousal from sleep, but does not meet the requirements for a hypopnea. Oftentimes this is upper airway resistance. Oftentimes they're the same thing. The main thing with this is that you will see their respiratory effort increase, so you might see the waveform on the respiratory belts get larger, or you may see the airflow coming from the nasal pressure transducer. You might see that waveform actually decreases a little bit, but not enough to be classified as a hypopnea. Also with the ARIRA, you don't have that oxygen desaturation that you have with a hypopnea. But with the ARIRA, there is always an arousal at the end. That is the identifying thing. It's something going on with their breathing, either increase in respiratory effort or a decrease in their airflow waveform. But there's always an arousal after it. That is one thing that sets it aside from the upper airway resistance. There is definitely a decrease in the airflow with upper airway resistance syndrome, but there isn't always that arousal. So let's just review again. Hypopneas, there has to be that decrease in airflow and a set oxygen desaturation. Typically we say a decrease in airflow of 30% and a 4% oxygen desaturation. although I did give you another possible requirement for those. We're going to ignore that for now. Remember, with upper airway resistance, there does not have to be an arousal, but there is a decrease in airflow of at least 5 to 25%. Then the difference between both of those and the RERA is there is always an arousal. It lasts 10 seconds. It could be an increase in the respiratory effort, so their airflow might stay the same, but their respiratory belts might increase, or it could be the opposite. The respiratory belts stay the same, but there is a decrease in the airflow channel. Either way, at the end of it, the patient wakes up briefly, which causes their sleep disruption. Let's go on to our next slide. Classifying severity. AHI, this is the apnea-hypopnea index, and this is the amount of apneas and hypopneas per hour of sleep. A mild AHI would be less than 5 events per hour. I think I have that incorrect on your slide there. Or no, that's right. Mild is greater than 5 events per hour. Moderate is greater than 15 events per hour, and severe is greater than 30 events per hour. This does not necessarily indicate the severity of the signs or symptoms of OSA, or obstructive sleep apnea syndrome. This only indicates the severity of how many apneas they are having per hour. Normal AHI is 5 or less per hour of sleep. Many of us have 5 obstructive apneic events during our night, and that is completely normal, nothing to worry about. When it starts to get above 5, that's when it starts to be significant, unless there are correlating symptoms. An RDI then is the respiratory disturbance index, and it depends on where you work and what your facility's policy is on this, but many facilities differentiate the AHI from the RDI. The AHI, again, is the amount of hypopneas and apneas per hour of sleep, so it only looks at those two factors. The RDI, however, and at many hospitals or sleep disorder centers, they will look at the sum of hypopneas, apneas, and RERAs per hour of sleep. Now, last I checked, as far as how insurance goes, they will only reimburse for the AHI being abnormal. So if someone had an AHI of 15 or greater, that they may seek treatment with CPAP, and insurance usually has full coverage for that. However, if a patient has an RDI of 15 or greater, but their AHI is normal, insurance companies may not reimburse the same. That's kind of the difference there. Is the AHI is considered more significant and the defining measure for treatment, whereas RDI, those who have worked in sleep recognize that RERAs are a problem and they can cause excessive daytime sleepiness. However, that hasn't become a standard of measure for insurance companies as of yet. Okay, let's go on to our next slide. Just to review what happens during normal sleep, we're going to do a little review of what we learned back in our first week. At sleep onset, the normal sequence of events is that there's going to be a decrease in minute ventilation, in part due to decreased tidal volume because the muscles start to relax. There's also going to be an increase in end-tidal pCO2. Remember, part of this is because we lose sensitivity to our CO2 levels. Also, we start breathing more shallow, we're more relaxed. And then along with this, because we have that decrease in muscle tone as we relax, there's also an increase in upper airway resistance. In REM, all of these worsen. We have an even more decrease in minute ventilation. Our respirations become very irregular. Our heart rate becomes irregular. We still have that increase in end-tidal pCO2 and even more increase in upper airway resistance because those muscles are completely paralyzed then during sleep. This includes the respiratory accessory muscles, many of the abdominal muscles except for the diaphragm, the pharyngeal dilator muscles. So all those muscles start to relax even more. They're essentially paralyzed. Again, with sleep apnea, then this can really create a problem. Age, as we get older, all of these things worsen if they change at all, they're going to get worse. They may stay the same, but if they're going to change at all, they're just going to get worse as we get age. Part of this is because as we age, we lose muscle tone. That's just a natural process of aging. And so if we lose more tone, then as those muscles relax, that's even heavier on the body, so that increases the possibility of upper airway collapse. Let's go on to our next slide. The occurrence of OSA. For Caucasian males, they believe it's in the area of 5 to 9%. They don't know how many have gone undiagnosed, though. They believe many have. OSA is associated with cognitive dysfunction, meaning difficulty concentrating or staying focused, logically thinking. That's what they mean when they say cognitive dysfunction. EDS, or excessive daytime sleepiness, high occurrence of EDS with OSA. Hypertension, there's a huge correlation between hypertension and OSA, and if you recall, we talked about that about a week ago with when you sleep, that's when your blood pressure resets itself. And if you're constantly being woken up out of stage 2 and stage 3 sleep, then your sympathetic system is constantly being activated, and that increases or raises that set blood pressure level. So it makes your normal blood pressure level increase. So instead of dropping back down at night when it's still elevated because of several arousals, then that resets your blood pressure so that during the day your blood pressure is even higher. So that there's the correlation between hypertension and OSA. There's a huge correlation between OSA and motor vehicle accidents, or MVAs. Excessive daytime sleepiness, you get in a car and you drive, you're at much greater risk for car accidents. They have connected, if you recall in one of our previous chapters, that drowsy driving is just as dangerous as drunk driving. So really, if you are sleepy, you are an impaired driver just as severely as someone who has been drinking alcohol. Cardiovascular morbidity is also associated with that, stroke, and diminished quality of life. Let's go on to our next slide. Nocturnal symptoms of OSA. The number one symptom is snoring. However, remember, just because someone snores does not mean they have OSA. That is not diagnostic at all. But most people who have OSA also snore. Gasps at night, waking up gasping, or just gasping in their sleep is very common. Chokes. Patient feel like they're choking or they're making the sounds that they're choking. Snorts are very common. Vocalizations are very common with OSA, moaning or talking in their sleep. Brief awakenings. These are so brief that the person themselves doesn't know that they've been waking up, but maybe their bed partner sees this. Frequent awakenings, insomnia, and unrefreshing sleep are all common symptoms. Most patients, I would say, are unaware that apnea is occurring. Many do, their sleep partner tells them, but if they don't sleep with someone or there's not anyone around when they're sleeping, most likely they have no idea they're doing that. Some other symptoms include restless sleep. I've seen patients so restless they look like they're swimming in their bed, and it's because they're not breathing, and so their limbs flail about. Diaphoresis is very common. Usually when this occurs, it is excessive to the point that their bed sheets are soaked with sweat. Excessive body movements. Dyspnea. This includes nocturnal paroxysmal dyspnea, which we see commonly with patients who have congestive heart failure. And then intrathoracic pressure swings may be a cause as well, but oftentimes they'll wake up short of breath. Esophageal reflux is very common. If you think about it as the airway collapses and that negative pressure sucks against that airway, that can actually create more pressure in the esophagus and then cause that gastric contents to come up the esophagus and enter the airway. So there's some reflux that can occur at night. Nocturia, this is frequent urination during the night, and this can be like 4 to 7 times per night is considered excessive. Enuresis, or wetting the bed, this can occur as well, although it's fairly rare. Dry mouth is very common, and this is because a lot of times a person will open their mouth in response to the obstructed airway. That's their body's natural response, is to open their mouth to breathe. So dry mouth is common, and in some patients drooling occurs. Bruxism can also be a symptom. So let's go on to our next. Daytime symptoms then, these are what the patient experiences when they're awake: excessive daytime sleepiness. They may also feel fatigue. Remember, if you are sleep deprived in stage REM, in stage N3, or delta sleep, or that slow wave sleep, remember you don't experience excessive daytime sleepiness from those two stages of being sleep deprived. What your body's going to feel is fatigue. That's where your clumsiness comes in and your inability to concentrate and remember, your short-term memory loss. Whereas deprivation of the rest of your stages of sleep, which would be primarily stage 2, that is what really causes the daytime sleepiness, the excessive daytime sleepiness. So if someone has obstructive sleep apnea, that will affect all their stages of sleep, not just a select few. So the result is all of the symptoms. They can have excessive daytime sleepiness, they can be fatigued, they can be clumsy or have poor dexterity, they have poor cognition, which is your decreased ability to concentrate, decreased ability to use your judgment. Short-term memory loss also occurs. These are the things that, if they're severe enough, these are what causes people to lose their jobs because they're not able to perform at work the way they should. And even scarier is that these people don't even realize that they are affected this way. So they don't realize that they're experiencing some short-term memory loss, or that they're having poor judgment, or they're not able to concentrate. They don't even recognize that that's happening. Some patients experience personality changes. Decrease in libido or impotence can also occur. This happens in a third of all patients, so that's pretty significant. Morning or nocturnal headaches, I should say. 50% of patients report this as dull and generalized. Oftentimes we think of this as primarily due to the hypoxia, but it can also be due to the high CO2 levels. Usually these patients will report they have it first thing when they wake up, but then after they shower and get ready for work, or after about an hour of being awake, the headache goes away. That's very common. Let's go on to our next slide. Comorbid conditions that occur with OSA primarily are hypertension and cardiovascular disease. However, they are identifying some more. Let's go on to our next slide. I like this slide because this really shows how OSA, or where OSA is implicated in other diseases. So let's start at the top of the screen. Cardiovascular disease, highly correlated with OSA. We see fluctuations in the pulmonary artery pressure and the wedge pressure that coincide with apneas. So this is telling us that OSA is putting some excessive pressure on the heart. It has to work harder when this happens, which contributes to cardiovascular disease. Now let's look at the circle on the right, cerebrovascular disease. This is multifactorial and includes hypertension, reduced cerebral blood flow, altered cerebral regulation, faulty endothelial function, accelerated arthrogenesis, thrombosis, and paradoxical embolism. OSA contributes to all of those factors, which increases the likelihood of cerebrovascular disease in response to OSA. So there's a high correlation between those two. Cerebrovascular disease, remember, this is just a stroke type of situation. Now the circle down at the bottom, obesity and diabetes. OSA has a strong correlation with metabolic syndrome, and they're really unsure of the connections at this point. There's not a lot of studies that say OSA causes obesity, or OSA causes diabetes, or that diabetes causes OSA, or that obesity causes OSA, but they just recognize that there is a strong correlation between the three things. So they think there's a connection there, they just haven't scientifically proven what it is. What they have been able to find out, though, that is OSA can increase insulin resistance, and we will get more into that later. Lastly, to the left, the circle to the left, hypertension. Remember, OSA increases the degree of systolic hypertension directly. It's correlated to the frequency of respiratory events, because those are causing the patient to wake up when their heart is supposed to be resting. This waking up increases sympathetic activity, which releases more epinephrine into the bloodstream. Remember, epinephrine causes vasoconstriction, which increases your blood pressure. also puts a little bit more work on the heart. So you can see how OSA has several effects on several different systems in our body. Let's go on to our next slide. Risk factors. Obesity and age, being over the age of 65, puts a person at increased risk for OSA. Males are more at risk than females. However, they found that this is community-based with a ratio of 2 to 3 to 1. Clinically based, what they've actually seen in the clinics is actually 90 to 1. So, android obesity and gynecoid obesity, the android obesity is more at risk than the gynecoid. Alcohol use, this induces relaxation of the pharyngeal dilator muscles, decreasing its ability to maintain upper airway patency, even more so than just when a person starts to fall asleep. So that naturally occurs as a person starts to fall asleep, but then if alcohol is involved as well, it relaxes those muscles even more, making them more likely to collapse. Race, African Americans, Mexican Americans, Pacific Islanders, and Far East Asians are at more risk than other races. With craniofacial abnormalities, we see an increase in OSA in patients with Marfan syndrome, Down syndrome, Pierre-Robin syndrome, micrognathia, and glossoptosis. And then some other factors that increase the risk is tobacco use and patients who have low vital capacity. These are not accepted risk factors at OSA right now, but they are suspected risk factors. They have been found to have a correlation. So let's go on to our next slide. Metabolic syndrome. There's still no definite correlation to OSA, but let's take a look at some of the similarities. Metabolic syndrome is characterized by a group of metabolic risk factors in one person. People with metabolic syndrome are at increased risk of coronary heart disease and other diseases related to plaque buildups in artery walls. So they're at more risk for stroke and peripheral vascular disease, as well as type 2 diabetes. The metabolic syndrome has become increasingly common in the United States, and it's estimated that over 50 million Americans have it. The dominant underlying risk factors for this syndrome appear to be abdominal obesity and insulin resistance. Insulin resistance is a generalized metabolic disorder in which the body can't use insulin efficiently. This is why metabolic syndrome is also called the insulin resistance syndrome. Other conditions associated with the syndrome include physical inactivity, aging, hormonal imbalance, and genetic predisposition. Some people are just genetically predisposed to insulin resistance. The American Heart Association and National Heart, Lung, and Blood Institute recommend that metabolic syndrome be identified as the presence of 3 or more of these following components. An elevated waist circumference. For men, that'd be equal or greater to 40 inches. For women, equal or greater than 35 inches. An elevated triglycerides, equal or greater than 150 milligrams per deciliter. A reduced HDL, that's your good cholesterol, in men less than 40 and in women less than 50. And then an elevated blood pressure, equal to or greater than 130 over 85 mmHg. And my notes ran off the page, so you might have more on your slide than what I can see on mine for that. So again, some of the similarities with metabolic syndrome, they have the abdominal obesity, arthrogenic dyslipidemia, that's your high triglycerides and your low HDL, high LDL. These are the things that foster plaque buildup in those artery walls, so that's bad. Hypertension, insulin resistance or glucose tolerance, the body doesn't use the blood sugar or the insulin properly. Prothrombic state, high fibrinogen or plasminogen activator inhibitor in the blood, and a pro-inflammatory state. This is elevated C-reactive proteins in the blood. However, all of these occur in metabolic syndrome. In people with metabolic syndrome, there's a high incidence of OSA. However, they don't have a direct correlation yet. So let's go on to our next slide. Physical exam. When we do a physical exam to check start ruling out or to start assessing a patient for possible OSA, these are some of the things they're going to look at. When they look at their BMI, a high BMI is 25 kilograms per meter squared, and that's for a Caucasian. Someone who is obese is going to be 28 to 33 kilograms per meter squared. Neck circumference greater than 40 centimeters has been highly correlated with OSA. Then the head, ears, eyes, nose, and throat exam, or the HINT. At the nasal septum, they're looking for asymmetry or enlargement of the nasal turbinates. At the soft palate, they're looking for low-lying bony structures and narrow or high arched palate. The uvula, they're just looking to see if it's enlarged. Tonsils and adenoids, again looking to see if they're enlarged. Presence of retrognathia or micrognathia, that's the placement of the jaw is at far back in their neck. Presence of teeth or dentures, which may affect treatment of OSA. And then there's the Malampati scale. This is a visual assessment of the crowding of the oropharynx, and it's on a scale of 1 to 4. 1 is a wide open oropharynx. 2, there's visible pillars and part of the inferior section of the uvula. 3, limited ability to visualize the oropharynx. The base of the uvula is barely visible. And 4, very crowded. The oropharynx and uvula are masked by the tongue. So those are some things they're going to assess when checking a patient for OSA, and some things that are going to be common with a patient with OSA. Let's go on to diagnosis. In order to be diagnosed with OSA, a polysomnogram or PSG must be performed. This can assess the full patient parameters needed to identify specific frequency, duration, and systemic effects of sleep-related breathing disorders. It can identify upper airway resistance syndrome. It can identify apneas. It can identify hypopneas. It can identify re-res. Remember the differences between all 4 of those. You should be able to define all 4 of those without having to look at your notes before you take the quiz. It can identify if they're having limb movements, seizure activity. We can tell how much time they're spending in each of the sleep stages. Also monitors their oximetry and their cardiac function, but their EKG. If someone has significant sleep apnea in the first portion of the night, they can do what's called a split night study. This is where someone's demonstrated significant sleep apnea. They can, in the middle of the night, put them on treatment such as CPAP, and then run the rest of the night titrating the CPAP pressure to eliminate as much apnea as possible. So then you can do your diagnosis and your therapeutic all in one study. The first half of the study makes the diagnosis, and then the second half is therapeutic with CPAP. We really only see this done with patients who have moderate to severe sleep apnea. They have to qualify to do that. NPSG only measures limited parameters: the oronasal airflow, chest wall respiratory effort, the EKG, and pulse oximetry. Not very helpful for diagnosis because we can't tell when the patient was asleep. Maybe they were holding their breath several times, so not very diagnostic. In pulse oximetry, this only can identify hypoxia. It can identify that they're actually obstructing, and it can't identify how severely it's disrupting someone's sleep. It can only tell us that their oxygen level is dropping while they sleep. Let's go on to our next slide. Upper airway resistance syndrome, or UARS. Chronic insomnia is a common symptom with upper airway resistance syndrome. Nocturnal awakenings, parasomnias, cold hands and cold feet, lightheadedness with standing or bending abruptly, low systolic blood pressure less than 105, nonspecific complaints of fatigue, muscle pain, and fainting. Usually when a polysomnogram is performed on someone who has significant upper airway resistance syndrome, their apnea-hypopnea index will actually be less than 5. They will have a large amount of re-res, or respiratory-related arousals, and their SpO2 typically doesn't drop that much. It stays above 90 usually. So if you are a doctor looking at this and you're saying, how can I treat this patient? Yeah, they have symptoms of being sleepy or fatigued, but when we look at their sleep, there's not a lot of work being put on the heart, where they're not at risk for hypertension. The question is, why should we treat it when it comes to doctors? And the answer really would be is to fix their daytime symptoms. But that's the issue with upper airway resistance right now. A lot of times it's not treated because it doesn't cause enough physical problems that damage other organs. So that's where the problem lies as to getting it treated. It's not as severe as obstructive sleep apnea and hypopnea on the body. It, so that's why it isn't treated as often or as thoroughly, I guess you could say. Let's go on. Non-surgical treatments options for OSA. The number one is weight loss. Most patients who have significant OSA are overweight or obese. So for these patients, weight loss may make a big difference. I know I've had one patient who came in for a sleep study and was put on CPAP, came back a year later. She had lost over 100 pounds. She had no apneas, was able to go off of CPAP. The following year, she came back again. She had put on 150 pounds because she had broke her leg and was bedridden or poorly mobile for a long amount of time. And guess what? She had to be put back on CPAP. So weight alone can have a huge effect in certain people. Not all people, but certain people. Prevention: avoid alcohol, nicotine, and sedatives because these can exacerbate OSA or make someone have OSA who just has some upper airway resistance. Practice good sleep hygiene and prevent sleep debt. Pharmacological treatments. This can be useful in secondary OSA, that is, they have it as a response of their hypothyroidism or thyroxine replacement. Treatment of excessive daytime sleepiness when CPAP therapy is already used and effective in the elderly. And then another possible pharmacological treatment would be the modafinil. Let's go on to our next slide. Oral appliances, these are used to prevent airway collapse. They open up the oropharynx by advancing the tongue and can move the mandible forward. This is typically reserved for patients who have mild to moderate OSA or those who are intolerant of CPAP and are not a surgical candidate. CPAP, this is our first line of therapy for moderate to severe OSA. It can be utilized for all severity levels of OSA. It uses positive pressure delivered to the upper airway to splint the airway open. Another way you may see this termed is used as a pneumatic splint. Appropriate pressure is determined by titrating the air pressure during a polysomnogram to find the pressure with the least amount of respiratory events, limb movements, and arousals. Let's go on to our next slide. Surgical management. Again, surgery is not an option for all patients with OSA. There has to be a thorough physical exam that helps identify if surgery is going to be possible. The statistics that I have heard is 50% of surgeries to eliminate OSA are successful, and the other 50% are non-successful, and the patient still has to go back to wearing CPAP. So it's kind of a risky thing. It just depends on how willing you are to give it a try, I guess. Nasal reconstruction. This is of limited use with OSA, but it can correct a deviated septum. It can correct nasal valve collapse and turbinate enlargement. They can grind down the turbinates to make more room up in the nasal passageways. Pharyngeal surgery. UPPP is typically what we think of pharyngeal surgeries. Success varies greatly. Again, this is one that 50% of the time it's successful and the other 50% it's not. In the UPPP surgery, they're going to remove the uvula, tonsil pillars, and the lower part of the soft palate. There's also another pharyngeal surgery called the UPF. This is a little bit more conservative than the UPPP and reportedly less painful recovery for patients. The genioglossus advancement and hyoid myotomy. These are two separate procedures, and both are used to enlarge the hypopharynx. It's pretty extensive surgery, but the success is much better than the UPPP. Maxillomandibular advancement. This is a major surgery. It actually has a success rate of 95%, but it's only indicated for those with alterable craniofacial abnormalities. For example, micrognathia, that would be someone where their mandibles placed very far back in their airway, so advancing that obviously is going to open up their oropharynx. Someone who has a normal facial construction, doing this procedure isn't going to really make a difference for them. Tracheotomy, this is a last resort treatment. However, it is 100% successful. Completely bypasses the upper airway. It's used primarily in cases of skeletal deformities, obesity, significant hypoxemia, or cardiac arrhythmias where CPAP has failed or is intolerable. I have known a few patients who just cannot tolerate CPAP or BiPAP, and so they opt for a tracheostomy. They keep it capped during the day and wear clothes that cover it up so people can't see it, and then at night when they go to sleep, they take their cap off and go to sleep. So let's go on to our next slide.